Welcome to Study Neuro and to this high-yield bedside guide on the complete cranial nerve examination. In this session, we'll systematically examine all 12 cranial nerves, from olfactory and optic through the eye movements, facial and hearing nerves, to the glossopharyngeal, vagus, accessory, and hypoglossal nerves, covering key observations at each step. We'll focus on normal findings, patterns of dysfunction, and practical bedside tips to help you perform the exam efficiently and accurately. By the end, you'll understand the function and clinical relevance of each cranial nerve, be able to perform the step-by-step examination, recognize normal versus abnormal findings, and use them to localize neurological lesions while integrating clinical reasoning. When we start a cranial nerve examination, the first step isn't touching the patient, it's preparing both yourself and the patient. Think of this as setting the stage for a reliable and safe assessment. Begin by making sure your hands are clean. It's a small action that protects the patient and shows professionalism. Then introduce yourself and explain your role. This helps the patient feel at ease and builds trust, which is crucial when you're going to examine their face, eyes, and head. Before proceeding, confirm the patient's identity. This avoids any mix-ups, and explain what the examination will involve. Patients respond best when they know why you're performing each test and what they need to do. Consent is essential, and it's also important to check if they have any pain, injuries, or movement restrictions that could affect the exam. Finally, position the patient so they're comfortable and ensure privacy by exposing only what is necessary. A well-prepared patient is relaxed, cooperative, and provides more accurate responses. These seemingly small steps set the foundation for a smooth, effective cranial nerve assessment. The first cranial nerve is the olfactory nerve, which mediates the sense of smell. At the bedside, the examination is performed by testing each nostril separately. A familiar, non-irritating scent, such as an alcohol wipe, is used, and the patient is asked to keep their eyes closed while identifying the smell. With normal olfactory function, the patient should correctly recognize the odor. Clinically, loss of smell is most commonly associated with ear, nose, and throat conditions, including nasal congestion and sinus disease. As a result, cranial nerve 1 is less helpful for precise neurological localization, although it may be involved in frontal base lesions and early neurodegenerative disorders. Cranial nerve 2, the optic nerve, is responsible for vision. It mediates visual acuity, visual fields, and pupillary responses, and provides the afferent input for the pupillary light reflex. Examining this nerve also allows us to assess the integrity of the retina and optic nerve. At the bedside, we start by testing visual acuity, assessing both near and distance vision. It's important to ensure the patient is using corrective lenses if needed. For near vision, cards should be held at about 14 inches, while a Snellen chart for distance vision is positioned at 20 feet or 6 meters. Next, we evaluate the pupillary light reflex, checking both direct and consensual responses. Fundoscopy follows, where we examine the optic disc margins, the cup-to-disc ratio, and the retinal vessels. Visual fields are assessed using confrontation testing in all quadrants. A rapid screening method involves the patient looking straight ahead while counting fingers held by the examiner at eye level in each quadrant. In a normal examination, the patient will have clear near and distance vision, pupils that respond promptly to light, a fundus with sharp disc margins and a normal cup-to-disc ratio, and full visual fields in all quadrants. Clinically, this assessment is extremely useful for localization. Visual field defects, such as quadrantopia, suggest post-chiasmal lesions. Accurate testing distance is essential because using the wrong distance can give falsely normal results. Fundoscopy can reveal optic neuritis, glaucoma, or papilledema, and abnormalities in pupillary responses help distinguish afferent lesions of the optic nerve from efferent lesions of cranial nerve 3. Cranial nerves 3, 4, and 6 work together as the oculomotor complex to control eye movements and coordinated gaze. Cranial nerve 3 also plays a key role in eyelid elevation and accommodation, making these nerves essential for binocular vision and accurate visual tracking. Examination begins with simple inspection. At rest, the eyelids are observed for ptosis, and the position of the eyes is assessed. Eye movements are then tested, ideally using an H pattern, which allows assessment of each extraocular muscle individually. Each eye is observed carefully for full range of movement while watching for any restriction. During this step, it's important to ask the patient if they experience double vision and to look for involuntary eye movements such as nystagmus. Accommodation is tested by asking the patient to shift their focus from a distant object to a near target, such as the examiner's finger. If the patient has difficulty understanding instructions, a simpler approach can be used by asking them to look left, right, up, and down. In a normal examination, eye movements are full and smooth in all directions, the eyelids are symmetric, there is no diplopia or nystagmus, and accommodation is intact. Clinically, the H pattern is particularly useful because it allows reliable assessment even when comprehension is limited. The presence of nystagmus often suggests central or vestibular pathology, while diplopia and restricted eye movements help localize lesions to specific cranial nerves within the oculomotor complex. An isolated sixth nerve palsy is especially important, as it may be an early sign of raised intracranial pressure. When examining the trigeminal nerve, you're really assessing two main things: facial sensation and jaw strength. This nerve supplies almost all sensation to the face and also controls the muscles used for chewing, so abnormalities here can be very localizing. I usually start with sensation. Using light touch only, I test the face systematically and always compare one side with the other. It's important to focus on the medial parts of the face rather than the sides, because dermatomes overlap laterally and can give a false sense of normality. I'll touch the forehead to assess the ophthalmic division, the cheek for the maxillary division, and the chin for the mandibular division. As I do this, I ask simple questions like whether the patient can feel the touch and whether it feels the same on both sides. Once sensation is assessed, I move on to the motor component. I ask the patient to clench their teeth while I feel the masseter muscles on each side. I'm checking for symmetry, bulk, and strength, which reflects normal function of the mandibular division. Reflex testing isn't routine for every patient, but it can be helpful in specific situations. The jaw jerk may point toward an upper motor neuron problem, while the corneal reflex, tested gently with a cotton wisp, assesses the trigeminal nerve as the sensory input and the facial nerve as the motor output. In a normal exam, facial sensation should be equal on both sides across all three divisions. Jaw clenching should be strong and symmetric, and any reflexes tested should be appropriate. Clinically, the key takeaway is that careful sensory testing can help localize lesions to a specific trigeminal division. Jaw weakness suggests motor involvement of V3, and abnormalities in the corneal reflex can indicate pathology in either the trigeminal or facial nerve. Done properly, this is a quick but very informative part of the cranial nerve examination. When examining the facial nerve, our main goal is to assess facial movement and symmetry because this nerve is the primary motor supply to the muscles of facial expression. It is also especially important for distinguishing between central and peripheral causes of facial weakness. Begin by simply observing the patient at rest. Look carefully at the face for asymmetry, flattening of the nasolabial folds, or incomplete eye closure. Even before asking the patient to move, these resting features can give early clues to facial nerve dysfunction. Next, assess facial movements by asking the patient to activate different muscle groups, always comparing both sides. Start with the upper face by asking the patient to raise their eyebrows, then ask them to close their eyes tightly. Gently try to open the eyes to assess strength. After that, move to the lower face by asking the patient to smile and then puff out their cheeks, watching for symmetry and any air leakage that would suggest weakness. As you go through these steps, pay attention to both the range of movement and the strength of contraction. Normal function is indicated by smooth, symmetric facial movements, strong eye closure that resists opening, equal eyebrow elevation, and the ability to keep the cheeks puffed without air escaping. The facial nerve exam is particularly valuable for localization. Weakness involving both the upper and lower face points toward a peripheral facial nerve lesion, such as Bell palsy. In contrast, sparing of the forehead with weakness confined to the lower face suggests a central upper motor neuron lesion. Remember that effective eye closure is essential for corneal protection, making this assessment clinically important beyond diagnosis alone. Finally, use clear and culturally appropriate instructions. Simple commands like smile are often more effective and comfortable for patients. When examining the vestibulocochlear nerve, the focus at the bedside is hearing. This assessment helps determine whether a patient has normal hearing and, if not, whether the deficit is conductive or sensorineural in origin. Begin with a simple screening test. Assess each ear separately by standing behind the patient and using a whispered voice or a finger rub near the ear. Ask the patient to repeat the words or numbers they hear. This quick step tells you whether hearing is grossly intact and whether further testing is needed. If a hearing deficit is detected, move on to tuning fork tests. Start with the Rinne test to compare air conduction and bone conduction. Place the vibrating tuning fork on the mastoid process and then position it just outside the external auditory canal, asking the patient which sound is louder or lasts longer. This comparison provides key information about how sound is being transmitted. Next, perform the Weber test by placing the tuning fork at the midline of the forehead or vertex. Ask the patient where they hear the sound best. This helps determine whether sound is being perceived symmetrically or is lateralized to one side. In a normal examination, whispered sounds are heard clearly in both ears. Air conduction is louder and longer than bone conduction on the Rinne test, and the Weber test does not lateralize to either ear. Clinically, it is important to remember that Weber and Rinne tests are only necessary if the initial hearing screen is abnormal. In conductive hearing loss, sound lateralizes to the affected ear on the Weber test, and bone conduction equals or exceeds air conduction on Rinne testing. In contrast, sensorineural hearing loss causes sound to lateralize to the unaffected ear, while air conduction remains better than bone conduction. Together, these findings help localize pathology to the external or middle ear versus the inner ear or vestibulocochlear nerve. When assessing vestibular function, you're essentially evaluating how well the inner ear and its central connections are maintaining balance and keeping the eyes stable during head movement. This is particularly important in patients presenting with dizziness, vertigo, or unsteadiness, where the key question is whether the problem is peripheral or central. Start by simply watching the patient. Even before you move their head, observe the eyes at rest. Spontaneous nystagmus can be an early clue to vestibular pathology. From there, ask the patient to follow your finger slowly. This allows you to assess gaze stability and detect gaze-evoked nystagmus, which often points towards central involvement. One of the most informative bedside tests is the head impulse test. Ask the patient to keep their eyes fixed on your nose, then make quick, small head movements to either side. In a normal response, the eyes stay locked on the target. If you see a corrective saccade, this suggests impaired vestibulo-ocular reflex function on that side. Next, assess balance more globally. With the Romberg test, you're looking to see whether the patient can maintain posture when visual input is removed. Increased instability once the eyes are closed suggests a vestibular or proprioceptive contribution. Watching the patient walk adds further information. Veering or imbalance can reinforce vestibular dysfunction. In a normal examination, eye movements are steady, gaze remains stable during head impulses, posture is maintained with eyes open and closed, and gait is coordinated. Interpreting these findings together is what matters most. An abnormal head impulse test combined with nystagmus usually indicates a peripheral vestibular lesion, whereas a normal head impulse test in the presence of other neurological signs should raise concern for a central cause. The key takeaway is to rely on observation and pattern recognition. Vestibular testing is less about isolated maneuvers and more about integrating eye movements, balance, and gait to localize pathology accurately at the bedside. When examining the glossopharyngeal and vagus nerves, we are primarily assessing the function of the palate, pharynx, and larynx. These nerves are essential for symmetric palatal movement, normal voice quality, and safe swallowing. Begin by asking the patient to open their mouth and say, "ah." Observe the soft palate as it elevates and the uvula for symmetry and midline position. Listen carefully to the patient's voice, noting any hoarseness or nasal quality, which may suggest vagal dysfunction. Testing the gag reflex is optional and should only be performed if clinically indicated. If you do test it, gently touch the posterior pharynx with a tongue depressor or cotton swab, and always explain the procedure to the patient beforehand. Throughout the exam, compare movements on both sides to identify any asymmetry. Normal findings include symmetric elevation of the soft palate, a midline uvula, a clear, non-hoarse voice, and a present gag reflex if tested. Clinically, asymmetric palatal elevation or uvular deviation indicates ipsilateral vagal weakness. Voice changes such as dysphonia or nasal speech also point toward vagus nerve involvement. While absence of the gag reflex alone is not always pathological, these observations are important for localizing brainstem or bulbar lesions and for assessing swallowing safety. When assessing the spinal accessory nerve, we focus on two key muscles, the trapezius and the sternocleidomastoid. These muscles control shoulder elevation and head rotation, which are critical for posture and coordinated movement. Begin by testing the trapezius. Ask the patient to shrug both shoulders against resistance and carefully observe for symmetry and strength. Next, assess the sternocleidomastoid by asking the patient to turn their head against your hand, feeling for equal power and smooth motion on both sides. Comparing right and left sides is essential to identify subtle asymmetry. In a normal examination, the patient demonstrates symmetric shoulder elevation and strong, even head rotation, with no evidence of muscle atrophy or weakness. Clinically, lesions of the accessory nerve are rarely isolated. They typically occur alongside broader brainstem or cervical cord pathology. When present, weakness may manifest as a shoulder droop, difficulty shrugging, or reduced ability to rotate the head. Evaluating CN11 in context with other neurological findings helps accurately localize lesions and guides further assessment. Now, let's focus on cranial nerve 12, the hypoglossal nerve. This nerve provides motor control to both the intrinsic and extrinsic muscles of the tongue, which is essential for speech, swallowing, and chewing. To examine the hypoglossal nerve, start by inspecting the tongue at rest, looking carefully for any wasting or fasciculations. Next, ask the patient to protrude their tongue and observe whether it remains midline or deviates to one side. You can also assess side-to-side movements and, if needed, apply gentle resistance to evaluate strength and symmetry. In a normal examination, the tongue protrudes in the midline, moves smoothly in all directions, shows no wasting or fasciculations, and has symmetric strength on both sides. Clinically, the pattern of deviation provides important localization clues. A lower motor neuron lesion causes the tongue to deviate toward the affected side, often accompanied by fasciculations and atrophy. In contrast, an upper motor neuron lesion may produce deviation away from the side of the lesion. Understanding these patterns is critical for assessing bulbar function and differentiating between upper and lower motor neuron pathology. When performing a cranial nerve examination, a systematic approach is essential. Starting from CN1 and proceeding through to CN12 ensures you don't miss subtle deficits and helps maintain consistency across patients. Before you begin, always prioritize preparation. Perform hand hygiene, introduce yourself, obtain consent, and position the patient comfortably. This not only protects safety, but also helps the patient feel at ease, which is crucial for accurate assessment. As you assess each nerve, observe carefully and test methodically. Look for asymmetries, abnormal movements, or sensory changes. For example, when testing facial movement or extraocular eye movements, subtle differences can indicate important neurological issues. Normal findings include symmetry, intact sensation, and coordinated motor responses. Integrating your observations with the patient's history and neurological localization allows you to interpret findings clinically. Not every abnormality is obvious, so careful correlation is key to forming an accurate assessment. Finally, thorough documentation is vital. Clear, structured notes ensure continuity of care and support future management decisions. Remember, proficiency comes with practice. Repeated bedside exams improve your confidence, speed, and precision. By combining preparation, systematic testing, careful observation, and thoughtful interpretation, the cranial nerve exam becomes a powerful tool in clinical evaluation. Thanks for watching. Don't forget to like, share, and subscribe to Study Neuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.